And not knowing why you're drawing them, will hamper you later in your clinical life. And so kind of knowing what they mean will help you be a better clinician, so that when you're ordering these labs, you're not like, oh, that looks elevated, what else, what's going on? I know you guys did LFTs in ClinLab, right? You talked about bilirubin, how it gets conjugated with AST, ALT, alkaline phosphatase, GGT. Did you guys talk about GGT? Yeah, so you kind of know a little bit about this, but I'm going to go a little in depth. And if you know this stuff already, well, cool, you can just go to sleep. That's okay. What do you guys have on Friday? Test, really. All right. Well, cool. So, but like this part. So if you don't understand this part of the lecture, the other parts are going to be a little bit more difficult. So, I'm going to start with like the hepatic or hepatoenteric circulation. So, you guys know that like your venous system, it goes down and goes to the guts, right? So you got your lower mesenteric and your upper mesenteric. Your blood supply goes from the pancreas and the spleen and the stomach, and it all gets filtered up to the liver. And why? Because the liver is going to filter all that stuff, and it's going to use that stuff to synthesize more stuff, right? And so if your liver doesn't function well, what do you have in the gut that will filter back up to the liver that it can't take care of? Like bacterial, viruses, funguses, fungi. You got like it won't make your proteins, right? So like you got your albumin and all of your coagulation stuff. So if your liver's sick, a lot of different things happen. And so kind of knowing where all the blood supply is coming from is important. And so understanding that like your pancreas, when your pancreas releases enzymes, those enzymes get circulated up into the liver, right? So for glycogenesis, glycolysis, all the synthetic stuff and all the chemical transformations go into the liver. Spleen. So how long do your red blood cells last for before they get?
120 days.
120 days. So then they get phagocytized and then broken down to heme, iron, ferritin, and then your heme. What happens to that? Huh? It gets recycled. But what's the biggest thing that happens to that heme particle? What's that green, yellow, brown stuff bilirubin, right? Bilirubin. So we're going to talk a little bit about that so that you guys understand that a little bit more. And then the circulation from the stomach, some of the big things that gets absorbed there and put through circulation are drugs and alcohol. And so that's a direct shot from the stomach right up into the liver. And so if you've got toxicity levels, that liver is going to get damaged straight from the stomach there. Okay, so that's some stuff that's important to know. And then the circulation, and then the liver itself. The liver is pretty big, right? So in females, it's about 1,300 grams. For males, it's 1,600 grams. It encompasses like 3 quadrants of the abdomen. So you got like the epigastric, maybe a little bit in the right side. You've got like a tiny little part of the lobe, epigastric, and then right upper quadrant, and then some of it's up underneath the rib as well. So if you've got inflammation there, you have a patient that comes in with some right upper quadrant pain, but it's kind of all over and in the back. It might be the liver. So you can palpate that and have pain in different quadrants from that. The circulation's important. So you got 2 blood supplies, right? You got the arterial, which brings oxygenated blood there. So if I've got somebody in shock, and they're not perfusing, they're getting end organ damage, they're not getting enough blood supply to the liver, and so now you've got ischemic problems, right? And so ischemia causes cell death. And so 75% of the other blood flow is from the portal vein. So that's everything coming back up to the liver to do all of its function. And so we can talk about, like, it goes from the porta hepatis to the blah, 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 to the blah, blah, blah. It really doesn't matter in the big scheme of things how it flows through. But just knowing that it has different branches to stuff. And that might become important, especially when you have somebody who's got, like, congestion. Maybe you have some Budd-Chiari syndrome, and we'll talk about that a little bit later. But having that ultrasound and knowing where the blockage is may be important a little bit later for what's happening within the liver. And then where the blood flows to. So if I've got right heart failure and I'm not getting good blood supply, it all backs up, right? So if you have backup on stuff, it's going to cause cellular injury and it's going to cause problems later. All right, and so this is like a little section of the liver. And so you've got, your sinusoids, you've got your bile canaliculi, and so like each one of your little hepatocytes does all kinds of functions, right? And so it's going to bring stuff back into the blood supply, going up to the right atrium and stuff after it's all filtered. You've got the hepatocytes are going to conjugate bilirubin, and it's going to go into the biliary system, down in the biliary system, down to the gallbladder, where it stores what? Bile, right? So every time you eat, that's going to squeeze, and so now you can do some fat. It'll surround little fat molecules so that you can absorb it throughout the digestion system. So there's a lot of things going on in the liver, and so we're going to do a lot of talking about the liver over the next 2 days. And so what are its functions? So filtration and synthesis, basically. So all this other stuff is great, but those are the two main functions of the liver. So you got carbohydrate metabolism, lipid metabolism, protein metabolism, synthesis of bile and bile salts and acids, activation of vitamin D, metabolism of drugs and hormones, the secretion of bilirubin, storage, and phagocytosis. Cool. So one of the biggest proteins that kind of comes out of the liver is albumin. And so you guys know about albumin from Chem Lab? Yeah, albumin's a pretty important protein, right? It's got a bunch of functions. It compromises half of the total protein content of plasma, and so it reacts with the osmotic pressure in your venous system. And so if I've got good albumin, I've got good osmotic pressure within my vascular system, and so it's going to keep things flowing. If I don't have enough, everything's going to kind of swell and leak out of the capillaries, right? So it kind of keeps all of the fluid with where it needs to be. Okay. And so some serum albumin function maintains intravascular oncotic pressure, preventing fluid leakage, carrier of several endogenous and exogenous compounds in the blood. It's a long-chain fatty acid, or it carries long-chain fatty acids, steroids, medications, binding to substances to reduce toxicity and to make things hydrophilic. So unconjugated bilirubin is hydrophobic. What does that mean? It's fatty, right? It's oil and water. So unconjugated bilirubin is oily, so it will disperse within the blood. So it binds onto albumin and gets carried to where it needs to go. Medications, your methadone, propranolol, furosemide, warfarin, methotrexate, those all get bound to albumin. And then it binds 40% of circulating calcium, transporter of hormones, your thyroxine, cortisol, testosterone, and it's significant antioxidant properties and involved in maintaining acid-base balance and blood level. Cool. So your serum albumin levels, highly sensitive to nutritional status and severity of illness. So your critically ill patients will have lower albumin levels. Maybe they have like problems in their liver and so they're not creating albumin. And so it's a very good indicator of the status of the patient, their health status. And it's actually a better indicator of liver function versus your liver enzymes, and we'll talk about that a little bit. And so the albumin level combined with physical exam or provide better assessment of the liver's function and ability. That's supposed to be PE, not PT. May remain unaffected in individuals with chronic liver disease and be abnormal in those who don't have liver problems. So it's not specific, okay? Low albumin level causes renal loss. If I have high fevers, intense exercise, I get rhabdo, I'm going to have losses of this protein. Kidney injury, so nephrotic syndrome, chronic kidney disease, end-stage renal disease. I'm losing all of my proteins, and so I've got problems within my glomerulus, and so I'm dropping proteins. And so when you have rhabdo, you have what color urine? Coca-Cola urine, right? And it's because you're losing a bunch of proteins. You have big old holes where you don't have that's supposed to keep those proteins in, and you're just kind of losing proteins. And then when you have kidney disease, you don't maintain your proteins. So, and we talked about GI loss, right? Inflammatory conditions. I'm gonna excrete my proteins within the bowel lumen, and I'm gonna poop it out. And so in lymphatic problems, so compression on the lymphatics due to lymphadenopathy, I can lose some proteins. Erosion, we talked about Crohn's disease, ulcerative colitis, and then celiac and scleroderma can do some protein loss as well. And then we talked about protein loss enteropathy. Intravascular volume expansion, so pregnant women in the second and the third trimester, they increase their volume, right? You guys will learn more about this next semester. But with increased volume expansion, it's going to dilute out other things, and so they start to leak things out in the capillaries, and they get edema, edematous. Increased catabolism, so in sepsis, I'm going to start metabolizing that albumin, and then I'm going to get that capillary leakage, additional reduced synthesis because my liver is failing. So I've got multi-system organ failure. And decreased production. So severe chronic liver impairment, or advanced hepatic cirrhosis, heart failure. So when you have heart failure, I have a combo of malnutrition, inflammation, liver dysfunction, protein loss enteropathies, and increased extravasation. So everything kind of leaks out in the periphery. Burns are important, and so as military providers, you may have a burn patient that you got to take care of, and when you've got to resuscitate those burn patients by giving them fluids. Well, they start leaking everything in the extremities, so they start to swell, and so you don't have anything intervascularly. They're losing their albumin, so sometimes when you're giving them or resuscitating them with fluid, sometimes you got to add some albumin so that you can keep things intervascularly. So that'll become a little bit more important during your emergency medicine. Nutritional deficiencies, so malnourished individuals and post-surgical patients because they're not eating. High serum albumin levels, dehydration, metabolic syndromes, insulin resistance. The insulin found to correlate with albumin production, so it can act as a trigger factor increasing the production of albumin in the liver. And so this is a handy little slide that just describes everything I just told you. So if you're a visual person and you want to learn what albumin does, this kind of helps you out. Talks about what it is, hypoalbuminemia, and then hyperalbuminemia, and then like the causes. I like to put the little pictures in there because I'm sure you don't like hearing me talk often. You need some visual stimulus. So what is bile? Bile I'll tell you what it constitutes in the next slide, but each day we have 800 to 1,000 ml of bile secreted by the hepatocytes daily. It's a yellow, brownish, or olive green liquid. If you do your surgical rotation and you have like some cholelithiasis, the surgeon will pull those out, and they're like cool looking little green stones. They look like green marbles. Pretty color, but it's all bile. It's stored and concentrated in the gallbladder, and it aids in the dispersion of ingestion and fat. And so I got a little picture there that shows you got your fat globule, you've got your bile that surrounds that, makes it more hydrophilic so that it goes through the system, then it breaks off. Your bile acids will go back into the liver to be recycled, and your fat will continue on for absorption. And this is a really cool slide. If you want to stare at it for a while, you can probably figure it out. But bile has bile acids, bilirubin, phospholipids, cholesterol, xenobiotics. What are xenobiotics? That's outside stuff that comes in that's mixed in with your bile. And then you got some electrolytes and glutathione. And so what this is showing is what the pathways cholesterol goes through in the endoplasmic reticulum, because those hydroxylation and reduction reactions and how they become part of bile. It's also got some how bilirubin's conjugated in there, and then it shows you on the top how the bile acids circulate as well. So it's kind of a cool slide if you want to stare at it for a while you're drinking beer this weekend. And so this is what it's made up of. So your bile salts are about 70% of bile. And then the bilirubin is a principal bile pigment. You got the conjugated versus unconjugated, direct versus indirect. And so when it becomes bile, what is it? Is it conjugated or unconjugated? It's conjugated, so all of you that are quiet will learn about that again. Learn about that some more. All right, so this is how it's, so these are the steps, right? So every 128 days, the spleen will keep those RBCs. You'll get a little macrophage that busts down the RBCs into components. So you got iron, you've got heme, so your heme molecule will go down and it'll become biliverdin. And biliverdin will hook onto that albumin particle, and so float through the blood back up to the liver. And so the liver, there's a transport mechanism within the hepatocytes that will accept that unconjugated bilirubin into the hepatocyte. And that little transport mechanism is important because there are some diseases that prevent that combination to come back into the hepatocytes. Within the hepatocyte itself, you've got another system where an enzyme is going to come along and add it's going to conjugate with this UGT enzyme. And so now it's going to be direct or post-hepatic bilirubin, so it's going to be conjugated there. Once it's conjugated, it's going to go into the biliary ducts, right? So there's another transport mechanism bringing it into the biliary system. It's going to go down and be stored in the bile until you need it. Once it gets into the enteric system, so now it's going to get converted into urobilinogen, right? So urobilinogen, you're going to have some go back into the circulation or through the kidneys, be excreted through the kidneys, but the rest of that urobilinogen is going to become stercobilin, which does what? It makes poop brown, right? And so the biliverdin that goes into the kidneys, that's going to make urine what? Yellow, right? Gives the urine its color. And if I've got too much of that, it's going to make the urine dark yellow, right? So, something to kind of think about when we go through this a little bit more. So some LFTs, right? They're a laboratory panel known as liver function test or liver enzymes. You'll hear it said that way as well. It's not really a representative of the liver function. It's more a representative of cellular damage. And so it's your hepatocellular disease. If I've got certain things like that there, it says ALP, which is alkaline phosphatase or GGT. That might be, that's a sign of cholestasis. So whenever I have something with my bilirubin in that cell, those are going to be elevated. If I've got cellular injury itself, like my hepatocyte has like little holes in it because I've got too much stuff that's going backwards, and it's going to expand that cell, it's going to leak out. Anybody know the other two? AST and ALT, right? And so those are going to be hepatocellular damage. So important to know the difference between those. So what's included in this liver function test, that you're going to order? You're going to order some LFTs. You're going to have serum aminotransferases. So you're going to have ALT, AST, alkaline phosphatase, ALP, total protein in that serum. And I'm going to have bilirubin, but it's going to be total bilirubin. It's not going to be conjugated and unconjugated bilirubin. You got to do an additional test for that. And then it's going to have the albumin in there. So some other markers that we have is a GGT. And so the GGT is not as common. The alkaline phosphatase can also indicate something with muscles, so it's not just the liver. So if you're concerned about determining where it's coming from, you can add a GGT to that test space to make sure it's coming from the liver. The LDH or lactate dehydrogenase, that's got a lot of different, any kind of inflammatory condition, or say somebody's got like some rhabdo or they got like some sepsis, your LDH will be elevated, so it's not specific to the liver. But your PT, your prothrombin time, right? PT, PTT, INR, you guys remember your intrinsic and your extrinsic pathways? That's all important to determine what's going on within the liver. So if I don't have that, which factor does the PT affect? 7, right? So if I'm not making my factors, I'm going to prolong that time where I clot. And so the PT will tell you if I don't have enough of those proteins there, if I've got some liver problems, that prothrombin time is going to be prolonged. Okay, and then platelets. So thrombocytes. Thrombocytes are super important, and they're also created in the liver. And so this is some normal values. I'm not going to ask you normal values and what looks elevated to you, because you're always going to have some sort of a pocket guide to tell you what normal is. But you've got your AST, ALT, alk-phos, total bilirubin, or T-bili. You can get your direct and indirect bilirubin and add those onto your labs, but it's going to be lab dependent. So once you get to your phase 2 place, I recommend that you go to the lab and find out how they want things ordered, because ordering labs sometimes difficult. You'll know what you need to order, but it'll be ordered under something different. So talking to your lab people is super helpful there. And then your PT, albumin, and total protein. And so hepatocellular injury has a pattern. And so I said if it's direct injury to the liver, your AST and ALT are going to be elevated. You're still conjugating bilirubin normally, and so your enzyme alkaline phosphatase that would be elevated in any cholestatic or gallbladder, or I'm sorry, bilirubin issues is going to be normal and just hepatocellular damage. And so this also will tell you if it's acute or chronic. So acute injury, acute hepatocellular injury, you're going to have large numbers, right? So it's going to be above 500 on those numbers. More chronic is going to be elevated good. It's going to be around 500. So high levels is going to be acute hepatic injury, so greater than 1,000. Maybe it'll be 899, so it's not a number that's going to give you each one. But so higher numbers for chronic is about 500. Acute is 1,000. All right, so ALT is found primarily in the liver, whereas AST is found in skeletal muscles and erythrocytes. So your ALT elevations are more specific for hepatic injury. So if you see it, your ALT is not super elevated, but your AST is, it's probably not coming from the liver. Make sense? All right, so transaminitis. That's what we say if somebody's got elevated LFTs or elevated AST, ALT. We say transaminitis. Often discovered on routine labs, otherwise asymptomatic patients. So you might see that it's an incidental finding. Your differentials are vast, so you need to do your thorough history, your PE, your evaluation for hepatic abnormality. Repeat the lab if you're in question. Maybe start looking at hepatitis and some of your viral etiologies, hepatic ultrasound, and then referral to GI, because they're the ones that are going to do scopes, talk to people about liver transplants. It's a little above your family practice PA level, right? And so if you've done all of your diagnostic studies and they're still elevated, you need help, so call the specialist. So this is important to know, especially in the military, right? 2 to 1 elevation of AST to ALT indicates alcohol-related liver disease, particularly with an elevated GGT. So you have a acute hepatocellular injury it may start affecting that gall or that bilirubin conduction through the hepatocytes. So in the military, what's most commonly abused drug? Alcohol. And I'm going to tell you, acute liver injury that goes into liver failure is ugly. That's like one of the ugliest ways that somebody's slow death. They can't create their coagulation proteins. They become altered mentally, and we'll talk about that a little bit a little later. But it's a very ugly, prolonged death, right? So it's Tylenol toxicity. So you guys have heard of people trying to kill themselves by taking a shit ton of Tylenol? Yeah, that's ugly death too. But like severe elevations in your AST, ALT, you want to do the ratio and see if it's 2-to-1 elevation, it's alcohol. This is telling you why, and who really cares, right? You're never going to remember this pyridoxal 5-phosphatase. Who cares about that? But just know that ratio is important. So I stole this from my favorite dude on Ninja Nerds, right? And so this is a really good thing to refer back to when we're talking about your differential diagnosis for hepatocellular injury. And so if you've got an elevated AST, ALT, it's a hepatocellular pattern. And if you go all the way to the left, DILI is a drug-related injury to the liver. And so those two are like Tylenol, alcohol, and then you're looking at vascular. So, we talked about Budd-Chiari, where you have a clot somewhere in the vasculature. CHF, that's going to cause some liver issues, and then ischemia. Viral hepatitis is on your differential. You've got autoimmune hepatitis, so you got to start drawing some more labs for that. And then maybe some systemic diseases, and then you've got your non-alcoholic fatty liver, A1, AT deficiency, so your antitrypsin 1, she has talked about that. That can cause elevations in your liver enzyme when they're super sick. Hemochromatosis, did you guys talk about that in one of your other classes?
Yes.
Yeah, and then Wilson's disease, you talked about that too?
Yes.
Oh, cool, we're gonna go through that a little bit tomorrow again. Just remind you. So GGT, enzyme that's present in hepatocytes and biliary epithelial cells, renal tubules, and pancreas and intestine. Mechanism of alteration are similar to those for alkaline phosphatase, but elevation in GGT levels can be observed in a variety of non-hepatic diseases, including chronic obstruction, chronic COPD, and renal failure. Cool. And so, again, like if you've got that AST-ALT ratio with a little bit of an elevated GGT, think alcohol. Okay. And so your biliary system, so you see we've got those biliary canaliculi within the liver. So those bile salts are going to go in there. All of your bilirubin's going to go in there. Your cholesterol, all those things are going to go into those little tubes and then go into the gallbladder, concentrate, and wait for a meal. And if I've got any sort of blockage within, like from low to high, I'm going to have what? What are my labs going to look like? Going to elevate because everything's backing up. So if it doesn't go down and it backs up, then I might see a lot more of that unconjugated and conjugated bilirubin where in the blood, right? Because it's not going down to the poop like it's supposed to. And so I might have some dark urine and some acolic stools, right? What does acolic stool mean? No color in my poop, right? Okay, so kind of knowing where like a stone is important as well. So if it's low in the pancreas, that's going to be called choledocholithiasis. So when it's involved with the pancreas, it's choledocholithiasis because it's down near the duodenum. If it's up a little higher before the pancreas, it's just cholelithiasis. Okay, make sense? We'll talk about that a little bit more. And so the cholestatic pattern, I may have a little elevation in my AST, ALT because things are backing up and causing injury to my hepatocytes. But mostly I'm going to have big elevations of my alkaline phosphatase and GGT. It's because at that biliary tissue, if I've got some issues with that bilirubin, those enzymes are going to be increased, and so I can find those on my labs. So ALP, or alkaline phosphatase enzyme that transports metabolites across the cell membrane. Liver and bone disease are common causes of pathologic elevations. Hepatic ALP in the presence of surface of bile duct epithelium. Cholestasis enhances the synthesis and release of ALP and accumulating bile salts increases its release from the cell surface. Cool. So again, like if I want to make sure that it's coming from the biliary system, I'm going to obtain that GGT. Or I could probably find that in my history and physical exam too, right? You know, if I've got somebody with right upper quadrant pain with elevated ALP, I probably don't need to get another lab, right? I already know it's there. Makes sense? All right, another one of the ninja nerd diagrams that we have here. So my diagnostic approach to cholestasis, so you can use this again in further lectures. If I've got an increase in that ALP and GGT, I want to get a right upper quadrant ultrasound. If I don't have any ductal dilations, meaning I don't have any stones, I don't have anything within those ducts that are causing backflow up to the liver, it's probably intrahepatic. And so I'm going to get my viral serology for all my hepatitises and all the other things. I might have a autoimmune hepatitis, so I'm going to get my ANA, my anti-smooth muscle antibody. And then cholestasis in pregnancy, so elevations in estrogen from OCPs or pregnancy can also cause some cholestasis. So, you know, are you pregnant? Yes, well that might be what the cause is, right? And then if I do have ductal dilation, I've got biliary obstruction. And so I might need that MRCP and that ERCP. We talked about those before, right? You guys tracking on what those are? So the GI dude goes in with his camera, and then he's got another little camera that he can extend up through the biliary tract to look for stones. They might have put some dye in there, and then under fluoroscopy can see what's going on. And so they can see some ductal, because you can't really see those on ultrasound, depending on what kind of stone they are, right? So I might have some common bile duct stones, so choledocholithiasis or cholelithiasis. Stricturing, we'll talk about the primary sclerosing cholangitis, and then malignancy, right? So if I've got a mass there that's causing all the backflow. Do you guys remember what inflammatory bowel condition is associated with PSC, primary sclerosing cholangitis? Which one? Crohn's or ulcerative colitis? Ulcerative colitis. Fail. All right. Jaundice. All right. Jaundice, also referred to as icterus, results in the accumulation of bilirubin in body tissues. So if it's not going down where it needs to go, it goes up into the circulatory system and it deposits. The first place it deposits is in the sclera. So what's it called when you've got yellow eyes? Icterus. And then it goes into the palms of the hands and the soles of the feet get yellow. That's called jaundice, okay? It's not clinically apparent until serum albumin level or bilirubin levels are greater than 2. And it appears first again in the conjunctiva. And so, you know, you see, sometimes it's really hard to tell, you know, because it might be very, very subtle on physical exam. Oh, did you go do a spray tan? And is this Paul McCartney? Kind of looks like him though, right? And so you got scleral icterus. So the jaundice characterized, you got prehepatic hemolytic. So if I've got some sort of a hemolytic problem where now my spleen is tearing up some red blood cells, you know, inappropriately. I've got all this hemosiderin and all this stuff kind of floating up in the periphery. I'm not going to have enough albumin to create a bunch of bile with it, right? So I'm going to have a bunch of stuff sticking around. So that's prehepatic. Hepatic, I might have some hepatocellular issues. So, you know, I've got things lysing my hepatocytes, and then now I've got conjugated and unconjugated bilirubin floating around. And then post-hepatic has already gone through the conjugation problems or the conjugation process. And now I've got some obstructive thing. Now I've got a bunch more conjugated bilirubin in the circulatory system. So kind of important to know that. And so we talked about this, right? You guys were all tracking on this. But one thing that I do want to show you here, because I talked about that, and you guys were all kind of nodding. Right here is one of the diseases that causes it not to go into the cell. And then into the biliary system, you might have something that's blocking it there, or some sort of disease blocking it. And then you might have a disease that you don't have that UGT or that enzyme that will conjugate that bilirubin. So those are all kind of important to note, because mechanical all makes sense, but when you have these weird diseases that cause these biochemical reactions, it's kind of hard to tell what's going on, okay? So, plasma elevations are predominantly unconjugated or indirect bilirubin due to increased bilirubin production, hemolysis. Impaired bilirubin uptake by the liver, that's the at the hepatocyte at the top, that's the Crigler-Najjar syndrome. Abnormalities of bilirubin conjugation, Gilbert syndrome. So you're unable to bind the glucuronate due to UGT deficiency. And then unconjugated, they might have some mild jaundice, normal stool color, and normal urine, because they're still getting some unconjugated bilirubin through the bowel. No bilirubin in the urine. May have some splenomegaly if etiology is hemolytic disorder. And then for both, like the mixed, you'll have the unconjugated and conjugated due to hepatocellular disease, so you're leaking both back into the bloodstream. Impaired canalicular excretion of bilirubin and biliary obstruction, often referred to as conjugated hyperbilirubinemia. Whew, you guys say that 10 times fast. Even though both fractions of bilirubin are elevated. And then conjugated hyperbilirubinemia, hepatocellular dysfunction, hepatitis cirrhosis, they're still making that conjugated bilirubin. Biliary obstruction, so it's further down the stream. So you've got choledocholithiasis, biliary atresia, carcinoma, we'll talk about those. And then hereditary cholestatic syndromes, Dubin-Johnson syndrome and Rotor syndrome. And that's just, we'll talk about that a little bit more later. And so for conjugated hyperbilirubinemia, for hepatocellular disease, that's the mix. You'll have jaundice, malaise, anorexia, low-grade fever, some right upper quadrant discomfort, dark urine, amenorrhea, enlarged tender liver, spider telangiectasias, palmar erythema, ascites, and gynecomastia. And then for conjugated for the cholestatic syndromes, you might have some jaundice, pruritus, and light-colored stools. And so for right upper quadrant pain, weight loss, this is for like the longer biliary obstruction, pruritus, dark urine, and then the colic stools. So what do? How do you work it up? You get your CBC, your CMP, your UA. I'm also going to add my bilirubin total and direct onto my labs. That's going to give me my bilirubin, my direct, and my indirect, and my total, so that I can figure out what's going on, which is higher. My LFTs, I'm going to get a hepatic ultrasound, and if I've got the cholestatic pattern and it's looking like I've got more conjugated bilirubin, I'm going to get that ERCP to evaluate those bile ducts. And so this is your diagnostic approach to hyperbilirubinemia. This is pretty cool too. I like how he describes this. If you guys are ever bored and you go and watch his little YouTube videos, he goes super in depth, but you really understand what's going on. So this has, like, on the pink side, that's your unconjugated hyperbilirubinemia. What do you think the urine and stool look like for unconjugated hyperbilirubinemia? What does your urine look like?
No color.
Hmm?
No color.
Yeah, normal. What do your stools look like? Oh, I might, is it, if I've got hemolysis going on, I'm still conjugating bilirubin, right? But I just have a whole lot of unconjugated bilirubin hanging around. So I'm still going through the normal pathways, I just have an excess of this other thing. And so you'll still have regular, normal-looking stools. If I've got negative on my hemolysis lab, so I'm going to check my ferritin, my iron levels, and if those are elevated, then I'm looking at a hemolytic anemia. If those are normal, then I might be looking at like Gilbert syndrome, Craig-Nagier syndrome, and rifampin. If I've got elevated total bilirubin, I've got elevations in my unconjugated and conjugated, it's mixed. And so if I've got a little elevation of my AST, ALT, then I know it's hepatocellular, something in the cell, so it's still conjugating stuff, but it's not going into the bile ducts, it's leaking out of the hepatocytes back into the blood. And so I've got hepatocellular injury. Does that make sense? And then if I've got elevations in my conjugated bilirubin, now my urine's super dark, I've got the acolic stools, because things aren't going all the way down the pathway. And so now I've got, it's conjugating just fine, but it's going all back up into the blood, right? So if I've got a increase in my alkaline phosphatase, I'm looking at cholestasis. Get my right upper quadrant ultrasound and look for obstruction. And then if I've got plus obstruction, it's, I've probably got a gallstone there. If I don't have one, then I might have a intrahepatic cholestasis, so one of those weird funky diseases that I'm looking at. If I've got normal AST and ALT, then you start looking at the super weird ones like the Dubin-Johnson and the Rotor syndrome. Make sense? Cool. So now we're looking at ERCP, and so if I've got that cholestatic pattern and I've got some of that mixed etiology, or I've got elevations in my conjugated bilirubin, I've got right upper quadrant pain, I'm going to order my ERCP, and so they're going to take that scope, go all the way down through the duodenum and go through the ampular evader and start looking through things. Some surgeons, if you have like a bad cholelithiasis that's causing like cholecystitis, and we'll talk about the gallbladder next week, but sometimes your surgeon won't wait, and they'll take them and they'll get the gallbladder out and they'll do an intraoperative cholangiogram. And then, so what they do is when they disconnect the gallbladder from its cystic duct, they tie off the artery. They may put a little, squirt a little dye into that cystic duct to make sure it's clear. And so they'll do that under fluoroscopy under anesthesia. So that's an intraoperative cholangiogram. But the ERCP is GI all the way. So if they got jaundice, I want to treat the underlying condition. After initial lab testing, patients with jaundice should be referred to GI for further testing and evaluation. And so this is a pretty good, like what we just talked through. You have like a little chart to kind of refer back to with the unconjugated bilirubin, the hepatic, and the post-hepatic. And so I would know those, just be familiar with them so you understand that. Any preguntas about the jaundice? All right, let's talk about, so I probably should have put acute liver injury and talked about that first, but we'll do that after the break. But a toxic liver injury, remember that's an acute liver injury, and so I might have DILI, which is the drug related liver injury, or alcohol. Okay, and so caused by hepatotoxic substances, acetaminophen, statins, NSAIDs, antibiotics, OTC drugs, supplements, and herbals. Do you guys talk about the P450 system in through other classes? Good, because I don't want to study those and talk about them again. But the P450 system does a lot of things with these drugs, and so if, those can cause a lot of issues with your hepatocytes. And then substances potentiating each other. If I overdose on some Tylenol and I just drank a bottle of vodka, that's going to make it even worse. Okay. And so again, the AST, ALT will be greater than 1,000 on those acute injuries. Toxicity classified by pathogenesis and pattern of injury. So direct hepatotoxicity is dose related to my medications. There's a latent period after exposure, and everybody's susceptible to it. An idiosyncratic reaction is unpredictable. It's not dose related. Some people might have a worse underlying liver problem, whether it's genetic. They take a medication and it causes some problems. And then indirect hepatotoxicity, use of drugs that exacerbate that pre-existing liver disease. And so Tylenol is one of the most dangerous medications that you prescribe. It's one of the best medications ever created, right? Because you can use it for pain, use it for fever. I broke the hell out of an ankle, got a gram of Tylenol, and I was good, until they took off my splint, and then I was bad. I needed morphine. But the Tylenol, what do we put in our combat pill packs? Tylenol. We got like an NSAID in there. You got a fluoroquinolone. Maybe you should add an antiemetic there, doc. But also put them in something that's a little rigid, because then your dose are going to come back with a powder packet. It's going to look like they got the cocaine in. So make sure you put that in something that will not get crushed. But what's your maximum dose of Tylenol per day? 4 grams. So anything over 4 grams is bad, right? And so normally if I give somebody a narcotic with the Tylenol, I don't usually prescribe like a combo med, because I want them to max dose their Tylenol and then add their narcotic on top of it, so like a breakthrough pain. So if I give them a Percocet and I tell them to also take Tylenol on top of that, they're not accounting for that additional 325 milligrams, right? So always do like the oxycodone with your Tylenol separately. And so make sure people know how to take it, because it's pretty significant if they overdose. And so you can use this nomogram. Have I ever used this nomogram? No. But in your ER rotation, or maybe in a pants test at some point somewhere, or one of your ER rotation tests, they might ask you what this is. And with Tylenol, you've got that latent effect. So you can take it initially, and then it just kind of accumulates in the system, because it's got to go through the enterohepatic system, right, and go back up into the liver. And so you can see on the line, you want that the reversal medication, but you're going to continue to check their Tylenol levels, and you can see where you're at with the grams. So you can see the hours post ingestion and how things kind of worsen, and then your plasma concentration. So toxicity, again, drug-induced hepatocellular injury, medications resulting in acute or chronic hepatitis, drugs inducing cholestatic injury, so non-inflammatory versus inflammatory, and then you could have some of the mixed injury. So treatment, discontinue offending agent, always whether they need inpatient versus outpatient, that's the severity of injury. All patients with liver failure need to be admitted. They'll probably go up to the ICU. I need the GI or hepatologist there, because they need to do a liver biopsy. And then I'm going to do the serial LFTs to observe to see if they're normalizing their values. Any questions on that? That was a lot, right? Good shit though. All right, so you guys take a break. We'll come back in 10 minutes. So liver injury. I probably should have talked about acute liver failure first, because it's drug-induced liver injury falls under acute liver failure. And so losses of the synthetic and filtering function cause direct parenchymal injury. So we talked about like your hepatocyte injury or hepatotoxic injury. So that's your DILI, your viral induced, so hepatitis. HSV, CMV can also cause direct injury to the liver. Antibody mediated, so your autoimmune hepatitis. Pregnancy related, so acute fatty infiltration of the liver. Maybe vascular related, so I talked about ischemic hepatitis, remember? So if somebody's in shock, if they're super sick, blood start, or they're hemorrhagic shock, we shunt blood just so that we can feed the heart and the brain, right? Everything else doesn't, is all secondary. So you can get ischemic liver damage injury, ischemic kidney injury, and so ischemia causes necrosis and death, right? So that's all important. And venous related, clots within the hepatic veins, Budd-Chiari, right heart failure, so hepatic vein congestion, so everything backs up and causes liver failure. So clinical findings, signs and symptoms, right upper quadrant pain, icterus, jaundice, encephalopathy. So this is important too. So I can't clear ammonia in the liver. And so now I've got free ammonia floating through the bloodstream, and it goes up to the brain. causes some cerebral edema, increases my intracranial pressure, and I can get altered mental status, asterexis, so that's the flappy tremor. So if you hold people's hands up, they flap, and so that's what that is. Coagulopathy, decreased clotting protein synthesis and procoagulants. So the 2, 7, 9, and 10, and the 7, I'm going to have my increases in my PT and my INR. Increased risk of ICH, so now I'm bleeding, right? So intracranial hemorrhage, GI bleed, cutaneous bleeding, so I've got like bruising everywhere, I've got bleeding gums, super ugly. You know, I told you like that Tylenol intoxication is ugly death. This is what I'm talking about. Hypoglycemia, so you know, I can't do any glucogenesis or glucogenolysis. Increased risk of infection, so I don't have those Cooper cells that are and complement proteins, so I'm not clearing that bacteria and all that stuff that I'm getting through oral ingestion. It's just all going through the enterohepatic system back into the liver. The liver isn't doing its job, and so now it's going into the bloodstream, causing sepsis. I can also get UTIs and respiratory failure from that. And so my workup, again, my LFT is greater than 1,000 AST ALT, is acute liver injury or liver failure. My ammonia level, I'm going to check that, and it's high. PT INR, it's going to be greater than 1.5. I want to check my Tylenol levels. Again, you know, history and physical exam too. So if somebody was like super depressed and tried to kill themselves, and you find them altered mental, and a bottle of Tylenol next to them, that's more going to direct you for what's causing that injury, right? But if I don't know, I'm going to do my viral serology, get my ANA, my anti-smooth muscle antibodies. For RADS, liver ultrasound with Doppler, maybe get an echocardiogram, making sure I don't have any CHF or right heart failure. Treatment, I want to reverse the underlying cause, so N-acetylcysteine for my Tylenol overdoses, just an example. Encephalopathy, I can add some lactulose, which binds my ammonia. The rifaximin, that helped like in the gut flora, one of their byproducts is also ammonia, so that medication will bind that ammonia in the gut. Coagulopathy, so I give them some vitamin K, some FFP, give them the stuff that they don't have. Hypoglycemia, I can give them some dextrose. If they've got an infection or sepsis, I want to add on the antibiotics, probably broad spectrum. Now I'm going to call GI and I want to get them a liver transplant, which they probably won't get because that's hard to do. And then they're going to end up dying on you. It's super ugly death. For hepatitis, you can get acute versus chronic. We're going to talk about the hepatotrophic viruses, other infectious etiologies, bacterial, fungal, parasitic, and other viruses, and some non-infectious hepatitis, so alcohol, drug-induced, and autoimmune. So your hepatotrophic viruses, so A, B, C, D, E, and G for your hepatitis. Your A, B, and C are your most common in the U.S., so those are the ones that you're going to see more of. Well, which ones do we vaccinate for? A and B, right? And so for viral hepatitis, there's 4 stages. Is this all review for you guys? Kind of makes things, you know, just not in a GI way, right? There's 4 phases. You've got the phase of viral replication, prodromal phase, the icteric phase, and then a convalescent phase. And so viral replication, so your hepatitises are either RNA, nucleated or capsid viruses, a DNA double-stranded, which is hepatitis B, and so they have different pathways that get into the cells. And they use the cell's mechanics to replicate themselves. So they get into the hepatocyte, they knock off their capsid or their envelope, they go in, they infiltrate your ribosomes and go in and embed themselves so that they can create more RNAs, affect the Golgi bodies to create more envelopes and combine and make a new virus, right? So when they're exiting the cell, they're going to blow up the virus, and so now they've got hepatocellular injury. If you have injury and they're coming out of the cells, you know, it's going to call some cytokines and stuff in too. And so those cytokines are going to attach one of these like cytokine receptors on your cell, and that's going to cause perforins to come in and make holes in the cell, and then some other stuff to cause apoptosis. And so now you've got apoptosis, cellular death. You don't need to know all that. Just follow me. But so that's all during the replication phase. And so your patients aren't symptomatic yet. They're just increasing their viral load. And so some of your laboratory studies demonstrates serologic and enzyme markers for hepatitis, but no symptoms. And then your prodromal phase, this is where they start getting sick. So that viral replication and that cellular death is going to cause some symptoms. So anorexia, nausea, vomiting, diarrhea. So it affects the CNS chemo trigger zone, causing retroperistaltic action. What is that? It's what it is. So the peristalsis goes opposite, and so everything's moving back up instead of back down. And then you may have some diarrhea with that as well. Arthralgias, malaise, fatigue, fever, weight loss. So your arthralgias, you've got like these immune complexes that attack like the joints, and so those will cause like a joint pain. Urticaria, pruritus, you ever hear like in physical exam findings if somebody's got red skin and they're super itchy, you always look for a liver, maybe like a hepatitis, a viral liver thing going on. And then this is weird too, alterations in taste. So some people like are, hardcore smokers, and all of a sudden it doesn't taste good anymore and they quit smoking. The icteric phase, this is like when stuff is really going down, right? And so now you've got the accumulation of your liver enzymes, so your AST, ALT are elevated. Icterus jaundice, so those complexes are going to attack the sclera first, and so their eyes are going to get yellow, and then it's going to go to the hands and the palms and the soles of the feet. Your urine's going to be darker because you're still conjugating bilirubin, right? But it's not going where it needs to go, and your cells are all lysine. And so now with all that conjugated bilirubin is going to go into the blood supply, and you're not going to get anything down to the gut. And so you're going to have the acolic stools and the dark urine. That makes sense? Yeah, all right. May develop right upper quadrant pain with hepatomegaly. So you're having all that cytokine action. You got the inflammation, and so that inflammation going to start irritating things within that right upper quadrant. So you're going to have some physical exam findings. You might have some hepatomegaly. So you're going to do a good exam there. And again, those immune complexes depositing in tissues. And so extrahepatic symptoms. You're going to have synovial, vascular, heart, and kidney inflammatory reaction. And phase 4, convalescent phase. And so this is where things start to settle down, but you've got liver injury. So you're not lysing a bunch more cells. You're not everything kind of stabilizes, but you might have some fibrotic reaction to that liver. So some areas that might start regenerating. So if you have a bunch of cellular damage and your body is trying to fix things, because the liver is pretty vascular, and so a lot of injury, like an acute liver injury, if you're not dying from it, it'll replenish, right? But if you're replenishing cells and you're recreating cells, now you have a high risk of mitotic issues. So I might start having things that go crazy, right? And so if things start going crazy, we got dysplasia, and dysplasia leads to cancer, right? So that's how hepatitis affects the liver for cancer. And so acute hepatitis A, it's second most common cause of hepatitis in the U.S. A significant decrease with our vaccine, and so military are getting vaccinated, healthcare workers are getting vaccinated, and so I think hepatitis A for anus. So it's a fecal-oral transmission, right? So your contaminated food and water travel to endemic areas. People not doing good hand washing and then tapping you on the lips. Just kidding. It's a single-stranded RNA virus, no envelope. That was just for those people that were like sleeping. So it's got a 30-day incubation period, and so it's an acute infection. It doesn't have a chronic infection. You got viral shedding in the feces of infected hosts for up to 2 weeks prior to onset of clinical symptoms. It's got low mortality, but it can progress to fulminant disease, but that's rare. And if there's a hepatitis C co-infection, that increases that risk for fulminant disease. So signs and symptoms after 4 weeks post-exposure: malaise, myalgia, arthralgias, easy fatigability, upper respiratory symptoms, nausea and vomiting, anorexia. Again, the smokers stop smoking. Low-grade fever, but the fever, once the fever breaks, you start getting jaundice after about 5 to 10 days. Presentation may initially be mistaken for viral gastroenteritis or a viral URI, so keep that on your differential. So when the jaundice develops, and so remember, dark urine, acolic stools. So what kind of bilirubin is that? Conjugated. It's going through the whole system, but your cells are lysine, and so now it's going, the conjugated bilirubin is going up into the vasculature, and you're getting more of that urobilinogen to the kidneys and not into the stool. Make sense? It's not going down, it's going up. Course of illness is typically 2 to 3 weeks. It's self-limiting and no progression to carrier state or chronic carrier state. So the laboratory findings: markedly elevated AST and ALT. So your LFTs are high. Moderate elevation of bilirubin and alk-phos, because I've got some damage there, so it's not going into the biliary system. Blood or stool will have HAV RNA positive. So the stool, you can get the RNA sample, so it goes through to the stool. The anti-HAV antibodies appear. Presence of IgM. So IgM is what? Acute or chronic? Acute. What's IgG?
Chronic.
Excellent. You guys are so smart. Immunized or past exposure, they get the IgG antibody. And so this is a cool little chart that shows you kind of like the progression of how things go and where you start seeing your elevations in your ALT, AST, where your IgM goes to and drops off, and where your IgG kind of comes up. So cool, right? I'm not going to test you on that. So treatment: bed rest if needed, symptomatic care. I'm going to give them some antiemetics, some antidiarrheal. I'm going to give them some fluids. Put them on quarters, no strenuous exercise or work for a couple weeks. Post-exposure vaccine if not previously vaccinated. And tell them don't make this worse by drinking alcohol and avoid hepatotoxic meds. E, mode of transmission, usually infected blood or blood products, sexual contact, and then mother to baby. So blood, sex, and perinatal. Okay. Variable presentation, mild to fulminant, risk of conversion to chronic hepatitis, and both acute and chronic infection. So your high-risk groups, again, the healthcare workers. So all healthcare workers get the Hep B vaccine. IV drug users, obviously, because that's blood transmission, and then prisoners. So the close contact, they're at high risk as well. Screening recommended for high-risk groups. So incubation period 6 weeks to 6 months. So the average is 12 to 14 weeks. The chronic hepatitis patient, substantial risk for cirrhosis and hepatocellular carcinoma. Remember, again, I'm having a lot of mitosis or mitotic reaction to fix all of my damaged cells, and so that's going to increase my risk for cancer. Men are greater than women. Has envelope, so this is a capsid, double-stranded DNA. Signs and symptoms: acute clinical syndrome is similar to presentation for the hepatitis A virus. Lab findings are also similar, greater elevations in AST and ALT than hepatitis A. And then serology, dun dun dun. All right, y'all ready for this? All right. And so we've got the hepatitis B surface antigen, right? HBsAg. It's located on the surface of the envelope of the antigen or of the DNA virus. If positive, patient is infected with acute or chronic. Serology is the hallmark of HPV infection. So if I'm worried about it, I'm going to get the HB surface antigen on my labs. It's what you are only given for your immunization. So when they give you an immunization, they're going to give you the antibody, the surface antibody. That's what you're given. So all the other ones you probably won't be positive for, right? And we'll talk about that here in a minute. Hepatitis B surface antibody, it's the antibody to the antigen. If positive, you're either cured or vaccinated, and it appears after about 6 months. So the hepatitis B core antigen, so this is core, it's on the capsid, so it's between the envelope and the capsid. Intercellular antigen expressed in infected hepatocytes, but we don't detect this one in serum. We only detect the antibody. The antibody, I'll either have the IgM or the IgG. So this is going to tell me whether I have an acute phase or a chronic phase. And so it appears shortly after the antigen is detected, which we don't test for. Detection of the IgM antibody for the core antigen is the indication of acute HPV infection, and then the IgM, or IgG, I'm sorry, will tell me if they've recovered or who have progressed to chronic. Will not have core antibodies after immunization, remember, because I'm only doing that surface antigen, so I won't have a core. So I'll have a negative IgG in immunized patients. And so the envelope antigen, this is in between the, well, it's on top of the envelope, sorry. If positive, increases replication and increase infectivity. So I know that that person's still replicating and they can still infect other people if this one's positive. It persists beyond 3 months, indicates an increased likelihood of chronic HPV. So they're still replicating and they're still infected, but they're at a chronic state. The antibody for the envelope is positive. I have decreased replication and decreased infectivity, so that will tell you that. And then you can also test for the hepatitis B DNA. If positive, increased replication and increased infectivity is going on, it parallels the envelope antibody. And so this is another cool slide you can refer to. It all kind of runs together, doesn't it? Makes my eyes cross. I start getting glassy-eyed. Look at those. I like this one a little bit better. So you got the surface antigen, and then you got the antibody. It tells you positives, negatives. And then the antibody for the core, IgM, IgG, tells you where they're at in their infectivity, and then your envelope antibody and antigen. So here's another little chart, tells you when the surface antigen's testable, so at like week 3.5 to the 24 week. You start your IgG or IgM for the core up to 32 weeks. The antibody for the surface, that's going to show up at like 32 weeks. And then the total antibody for hepatitis B core, that kind of hangs out for a little while because you're building antibodies for it. So treatment supportive, like hepatitis A, antiviral therapy reserved for patients who develop severe disease. Encephalopathy or coagulopathy indicates severe disease, so they require inpatient management. Prognosis, illness lasts usually 2 to 3 weeks, and they usually are completely recovered by week 16 unless they go chronic. Prevention, screen donated blood, serology testing in pregnancy, safe sex practicing, safe handling of food and body fluids, vaccination. Hepatitis B immunoglobulin administered for known exposure and followed by the vaccine series. So it's not a one and done, right? So this is for the vaccine. All right, C. 50% by injection of drug use, or injected drug use, transfusion or infected blood, body piercings, tattoos, hemodialysis, STDs and marital transmission possible, but it's low risk. Co-infection in HIV positive patients is common. No vaccine available. High risk of conversion to chronic state, so significantly increased risk of cirrhosis and carcinoma. It's a single-stranded enveloped virus. So converted transmission during fisticuff has even been reported. So, full slide, back in the day when you're boxing, you could transmit hepatitis C. That's just for fun. All right, incubation period, 6 to 7 weeks. Clinical illness is usually mild, often totally asymptomatic, but you'll have these waxing, waning elevations of your liver enzymes. So if you see somebody who has no symptoms and they're just there for a general screening, or within that kind of age range where they might party a lot, you might want to check for a hepatitis C level. Natural history is either spontaneous clearance of the virus or progression to chronic disease, and it could be an acute or chronic infection. So laboratory findings, you got your panel or your LFTs, similar to A and B. You got the anti-hepatitis C B or EIA testing. So remember that's that assay, that immunoassay test that they do. If positive, equivocal, obtain the HCV RNA test for PCR. If positive, HCV RNA patient is infected. If positive less than 6 months, it's an acute infection, and greater than 6 months, it's a chronic infection. So if you confirm it, obtain a renal panel and urinalysis. You want to observe for proteinuria, hematuria, and or reduction of GFR. And so this is your pattern for your hepatitis. Cool. Treatment, initiate antiretroviral therapy immediately upon diagnosis. Direct-acting antiviral DAA regimens, and so these are some of the meds that you can give for that. Very high cure rates, but very expensive. So you guys remember when they started coming out with the cure your hepatitis C? Those meds are still out there, but they're super expensive. You can combination pegylated interferon alpha 2A and B plus ribavirin is less expensive but lower cure rates. So people have known with the hepatitis C virus. Prognosis, clinical recovery typically in 3 to 6 months. Up to 80% converge into chronic disease. 30% develop cirrhosis, which increases your chance of hepatocellular cancer, right? So increased mitotic rates, increased risk of problems with that, and then increased risk of cancer. So here's just a little FYI. So if you've got patients with a hepatitis C infection, like I said, they're at high risk for fibrosis. And so to tell if somebody's got a fibrotic liver, they usually need a liver biopsy, but it's a super invasive test. The other thing that you can use is this FibroSure test, but it's super expensive. So to determine if you need to do a liver biopsy, you can use this APRI score. And so this is just FYI information on how to determine if somebody needs a liver biopsy. So you take that AST, divide it by that, or AST upper limit of normal, divide that by the platelets and multiply by 100 and you get an APRI score. So APRI score greater than 1.5 means a liver biopsy. So D. Defective RNA virus, single-stranded with envelope, causes hepatitis only associated with HBV infection. So if somebody's got HBV, you also want to clear them for hepatitis B virus. It doesn't happen on its own. It's got to have a friend with it. Okay. Specifically, only in the presence. Oh yeah, I already said that. Usually, route of infection was IV drug use and other routes similar to HBV, sex, blood, and perinatal. Tests for patients who have acute hepatitis B, and it's mainly a chronic infection. Okay, hepatitis E. Major cause of acute hepatitis throughout Central and Southeast Asia, the Middle East, and North Africa. So it's not super common in the U.S., but where do we go as military people? Everywhere, right? So consider it in patients with travel to endemic areas. It's fecal-oral transmission, so waterborne outbreaks or contaminated water. So remember when they talk, only drink from approved sources so you don't get the hepatitis E. Causes mild to moderate clinical illness. It's severe in pregnant patients. So pregnant women with this, that it's super common to progress to fulminant hepatitis, and that increases their risk of mortality and morbidity. So pregnant women, hepatitis E is bad, okay? Mainly an acute infection, there's no envelope, it's just a single-stranded RNA virus. Serology, I'm going to get the HEV RNA plus acute infection, IgM plus past exposure cleared HEV RNA. I do the IgG, but the IgG only hangs around for 2 to 3 years. So if you've gotten that IgG there, it means they've had a prior infection, but that's going to clear after 2 to 3 years. Make sense? I have another little chart. Make this kind of simple. Chronic hepatitis, infection with hepatitis B plus or minus hepatitis D, or hepatitis C for greater than 3 months. Persistent, so I'm going to check for persistently elevated AST and ALT, so that's going to kind of direct me to a chronic infection. And persistent presence of the hepatitis B surface antigen and the antibody for C, and the antibody for C again, so antigen, I'm sorry, or histologic findings in the liver biopsy. In the absence of concomitant cirrhosis, patients may be asymptomatic. So the goal of treatment is to inhibit viral replication. Secondary goal is to reduce symptoms, prevent or delay the progression of chronic hepatitis to cirrhosis and hepatocellular injury. So how do I do that? I give them some antiviral therapy. And so you do the pegylated interferon for 48 weeks, or a nucleoside or nucleotide analog, so tenofovir or entecavir for 1 to 2 years. So long-term therapy for these guys. The main goal of treatment for chronic HCV or hepatitis C virus, eradication of the virus. Secondary goals, again, reducing symptoms, prevent or delay progression of chronic hepatitis to cirrhosis or hepatocellular carcinoma, and treat extrahepatic complications. So the regimen selected by the genome type and other patient factors. Probably that's all GI guy stuff, right? So, if you have chronic hepatitis, I definitely get a specialist involved to help you out with the management. And so here's a cool little chart. Again, my Ninja Nerd friend. He kind of gives you that acute phase. The window is basically in your prodrome or icteric phase, so that's going to tell you you've got the antigen and the antibody, what things that you're going to see there, and then what it looks like during recovery, and when as opposed to immunized. And then, or you could do chronic, like where they're replicating, so the chronic replication and infective stage. Versus the chronic non-replication. So they still got the chronic infection, but they're not infective. And then it gives you a little stuff about the hepatitis C, the D and E on there as well. So you guys can look that over. It kind of, I like things that just bring everything together, right? So you're not looking at 15 different slides trying to figure out what everything is. If you can figure out how all those progressions and what they look like, that'll help you immensely in clinical practice. And guess what? In like 2 years, you're going to forget what everything is anyway, so apologies. Autoimmune hepatitis, unless you work in the immunology clinic, right? Then you'll probably know more. Autoimmune hepatitis, it's a form of chronic hepatitis due to antibodies. So again, a dysregulation in your immune system. Much more common in women. Has a very clinical presentation. Some patients are discovered incidentally. And so the signs and symptoms will vary. You'll see that transaminitis, so elevation AST, ALT, found incidentally during routine screenings in labs. Oh my God, you've got hepatocellular injury. Now I need to do a workup, right? So mild or non-specific findings, maybe they're complaining of some fatigue, lethargy, malaise, anorexia, nausea, abdominal pain, and itching. Again, itching, pruritus, you think liver, right? Got the itch scratch. Check for their LFTs. Arthralgias involving the small joints. Remember, you get those immune complexes that attach to your synovial joints. Acute presentation of hepatitis and liver failure with profound jaundice. So now they're super yellow. Elevated PT. So their coagulation factor 7 as well, right? marked AST, ALT elevation of greater than 1,000. So that's a liver failure. Extrahepatic manifestations are common. Again, the arthritis, Sojourn syndrome, thyroiditis, nephritis, so things are inflamed. Ulcerative colitis, remember that's an inflammatory condition and it turns on some weird things, right? And so now you got immune dysregulation that's affecting other things. Combs positive, hemolytic anemia, increased risk of cirrhosis and cancer. Dun, dun, dun. Any questions? No? Did I bore you to death? Sorry. I didn't write the curriculum, man. Promise.